welcome to the Stronger After Stroke podcast. My name is Rosa Hart. I'm the stroke nurse navigator for Norton Healthcare, and today we will be talking about neuroplasticity and how to optimize your recovery after stroke to have the best life possible. So today we have some special experts joining us, our physical therapist, Colin, and our occupational therapist, Keegan, Humphrey. So thank you so much for taking time out of your busy schedule where you see lots of neurological patients to get this message out.
Yeah. Thank you for having us.
So one of the most common questions that I've encountered from stroke patients, no matter what their symptoms were with their stroke, is how to deal with the fatigue and if fatigue is normal after a stroke. I'll have patients who got alteplase or had a mechanical thrombectomy and all their stroke symptoms went away, but then they're home and they are just abnormally exhausted. And they're like, why do I feel this way? And when everything else with the stroke went away. So would one of you like to speak to that?
Yeah, so as far as like stroke fatigue goes, it's very common. It's probably more than 80%, I think. Yeah. So it's very common after a stroke. So if they're feeling like that, they're definitely not alone. But unfortunately, right now, they don't really exactly know why that is. There's a lot of different recovery processes that may go into it, as well as you got a lot of emotional fatigue with dealing with kind of everything that you're going through, the mental fatigue, and then also the physical fatigue. So all of that is compounding and then can kind of result in a fatigue that seems almost overwhelming and may or may not get better with rest. So at this time, they don't really know, but it is very common after a stroke, so they're also not alone.
So how do you encourage people to deal with that?
I was going to say, whenever I talk to clients, one of the biggest things is, you talked about it, rest alone is not the only, thing that can help, but you do want to take short naps. That is helpful. One thing too is always talk to your doctor because medication side effects, it could be impacting the stroke fatigue. I'd always check the medications to make sure that that's not impacting it. Diet and exercise would be one that we would want to do. And just know that it is a long haul. And so it's not going to be done and, cured in 3 weeks. It's going to be a period of time. So that's what I tell
maybe longer
clients.
than a year.
Right.
Potentially, yeah.
Yeah. And I think that's a really interesting perspective to consider is if you're sitting in a classroom all day, which for those of us who have spent a lot of years in school, you can spend all day sitting at a desk, listening and learning, and then walk away and feel completely exhausted, even if you didn't move all day. And I think that's a really important thing to remember is you're learning a lot when you've had a stroke. You're changing routines, like if you are changing up your exercise or your diet. And so that can be really exhausting.
Yeah. One thing too that we always talk about is watch your stress levels. Because I know you kind of harped on that because I know with education, you're being tested and it's like, that is stress. And then especially like after, a stroke, dealing with like the dynamic family environment, and then that's stressful alone. Yeah. And not being able to engage in those same activities as you once were. Yeah, if we can manage that stress, then that also helps.
Yeah.
Getting a schedule together. That's actually one intervention that we talk about is if we can get things organized, because, as human beings, we like organization, right? Even as a chaos organization is like one of the biggest things that helps us, combat this.
Right. A lot of people live in a state of organized chaos in that it might look like a mess, but I know where things are. So if your visual field changes and you can't see where things are, then that can really be upsetting. So
and there's also obviously different support groups. There's also, you bring in the family dynamic. There's also caregiver support groups. But, the importance of like mindfulness, meditation, all of that can also help with stress and kind of relieving that.
Yeah. It's already multifaceted and we only addressed the first question. But there's just so much to stroke recovery. It's not one size fits all and everybody is different. Right. And that's one thing that I think have all struggled with when we're talking with a patient is they'll ask, how long until I get back to normal? So what do you say when a stroke survivor says to you, okay, how long is it before I'm going to get back to the way I was before?
When I address that question, usually I tell them, everyone's so different. And I honestly cannot tell you that answer, to be completely honest. What we'll do is take it in strides. Because if you sit there and you harp on, oh, when am I going to do this, instead of like taking it in short strides, I've had more success with people going in short strides than going long haul. I need this now, instead of being like, oh, let's short it, set small goals.
Yeah. And I mean, for me, I'll be upfront and honest and say, you may get back to normal. You very well may not, but we're going to treat you how you are today. And then to Keegan's point, take it day by day, short strides. Okay. So every little bit of improvement is still improvement from where you started off at. So instead of kind of looking at the end goal of where you want to be, kind of look at where you started from and then take note of that improvement, because then that is just kind of further motivation to keep doing what you're doing.
Exactly.
But keep that end goal too. Do not lose sight of that. That's going to be one of the most important things too.
Yeah. But for me, I feel like a lot of patients will almost get down because they are stuck in this circle of like comparison from where they want to be, once were, and where they are now. And it is almost like self-defeating, because they're stuck in a vicious circle of comparisons. So trying to break them out of that and, recognize like, hey, last week you may not have been able to take that step. Today you are. So taking it day by day, short strides, literally.
And celebrate the wins along the way.
Yeah.
Yes.
Yeah. And I think this is a good time to mention that, in the past we would have heard providers say, however you are at 6 months or at 1 year, that's your new normal. And so don't expect to change a lot after that. What would you say to that as specialized neurological
no
rehab therapists?
Research has already shown that you can make gains post 1 year, 20 to 30 years after your stroke. So to tell somebody that they can't make gains 30 days, 6 months, that's ludicrous.
And I think it's gotten
It's
better.
outdated information.
Yes.
Because that was the established understanding in the neurological community before that research was done and publicized. And not all the people in healthcare do read neurological research, right?
Yes.
So I'm so thankful that we have people who are up to date here to share the latest updates, because it might be common knowledge to us. We've known it for a while, but it may not be common knowledge across the country for non-neuro specialists, right?
Correct.
Sure.
But to Keegan's point, he already brought research. If there was no benefit to individuals who have had a stroke beyond 6 months, a year, whatever, they still wouldn't be carrying out these, clinical trials for different therapeutic interventions. So the fact that, the research is continuing and they are specifying individuals who have had, quote unquote, a chronic stroke, that is enough to show that, yes, improvements can be made no matter where you are on the spectrum.
That's so exciting, because there is so much hope for recovery, even if it's been a long time. Like, I know I've talked to people who are 7 or 15 years out, and all of a sudden they'll have a breakthrough on something they never thought they'd be able to do or experience again. So
now, one thing to keep in mind too, and you're bringing up good points, is that, the older that we are, it's going to be a lot harder to make those gains, but it is still possible. Like you said, a 7-year-old is going to make an easier time, making those jumps than someone who's, my age. I'm 40. So
that's why I haven't learned Italian.
Right.
Because you tell yourself you're too old? Is that why?
No.
Case in point. But the older we are, it takes longer for us to learn things. So as long as, everyone understands that, then it makes it a lot easier and, rewarding.
Yeah. And, to that point, it also means that it's not going to happen in a week, right? So it's going to take practice, and you can't expect results right then and there. In an era of instant gratification, this is not one of them. So
this is a slow process. So let's talk about spasticity. Is that something you see a lot in stroke survivors?
absolutely.
Oh, yeah.
Unfortunately, right now, there's not really a good long-term treatment intervention for spasticity. You can take, different medications. Those obviously come with different side effects. There's also Botox injections, but, it's trying to find a fine line between how much is enough to kind of limit it versus how much is too much to the point where you can't really actually use that muscle anymore, right?
Oh, yeah.
There's other things that you can do, like prolonged stretching. So Keegan and I are very big on kind of using like different splints and braces for kind of those low load, prolonged stretches.
So the braces hold those muscles like in tension for longer? Is that how they work?
Yes. So especially like at night, some individuals will have a good amount of tone and their hands will kind of curl up. So kind of wearing a splint at night can help limit that. You can also do like heat, ice. People respond differently to different things. There's also been some research on dry needling and spasticity. So I'll tend to incorporate some of that if I think it would be beneficial. I don't know what your other thoughts are on it.
Kind of hitting on the splint aspect. I mean, everyone has to understand, well, not everyone has to understand, but there are static braces, right, that'll hold in a stiff position. And so then there's also like a dynamic splint that will, when the spasticity kicks in, it'll move, but once that muscle tires out, it'll go back in the stretching position.
Really?
Yeah, and
So it kind of rebounds?
Yeah. And
Interesting.
So what I liked for people is that, what I've seen, especially in clinic, when the spasticity kicks in, you got a static brace, it'll pop out. And I'm sure you've seen it too. But then if you go dynamic, it'll, kind of allow that to occur, but then it'll go back into a resting position. And that's what you want because it's in a stretch, especially at night. Now, they are bulky. I mean, they're kind of bulkier than, obviously, they're much bulkier than a static brace. But, that's one thing I like to do. With the bracing aspect, and kind of going back with like the medications, again, Colin's right. Look at the side effects too, but then we want to try and avoid surgery as much as possible because once you get into surgical intervention, you're already going to lose muscle function, to its most capacity, especially when you not going in a tangent, but like scar tissue and stuff like that. You have to worry about that aspect, and that healing. And so we want to try and avoid surgical as much as possible. So, yeah.
And there are a lot of risks with surgeries as well.
Yeah.
So if you can try a non-surgical intervention first and see how it works, then that's a really good approach.
Right.
Yeah.
I don't know if you really want to talk about like medications, but
I really don't.
right, baclofen pumps and stuff like that. I mean, that's another area to watch out for.
I'll wait until I have my prescribing providers on to talk about medications.
Oh, no, that's fine. But that's one. But it's an intervention that you would use for spasticity. Then, not to, again, you're not going into it, but as an example, yeah.
And then would you say massage therapy helps with spasticity, or when would that be helpful?
Honestly, my personal take is if you're going to have somebody help out and like stretch and do some, like myofascial release, right? That would be one technique that I would use like during my intervention. So, that's along the same lines, not the parallel really, but I would use those. So yeah, I think it's appropriate.
Yeah, and especially if, you have a spastic muscle, it's also going to be tight and potentially limit your range of motion. So that's when you would want to use some splinting, bracing. But you would also want to use up some manual skills, massage, myofascial release to try and kind of lengthen that muscle and prevent it from getting too tight and improve range of motion.
Can you describe how myofascial release would work? Because those are some big words. What does that mean?
Well, in a nutshell, so when we stretch a muscle, then the theory behind it is like muscle has memory. So if we think about contraction like this, what we're going to do is try and help break up those adhesions really and lengthen those out. So we're going to do low load prolonged stretching for that aspect. And so, like, for example, with the shoulder, I might do like a joint distraction, not dislocation, distraction. And so I'm easily kind of lengthening that muscle and allowing it to, get that low prolonged stretch. And then I'll go through like range of motion. And one thing to kind of, I don't know, do you want to add anything to that one aspect?
No, but, breaking up kind of the muscle tension, so the muscle fibers itself, as well as kind of the fascia that surrounds the muscle, those can also get adhered, and then a lot of pain can come from that as well. So trying to kind of break up those adhesions is what you would use that massage or different other soft tissue mobilization techniques.
I think I said the technical term, I guess unwinding would be that one, right? We want to unwind. Yes.
Yeah, literally unwind those muscles.
Yes.
They're wound too tight. So some people who have had strokes encounter difficulties with memory, either short-term memory or longer-term memory. So what can they do to help with memory?
One thing when clients come to me, and that's one of the things that they want to discuss and talk about, the first step is always going to be like, okay, let's look at some compensatory techniques, right? So as an example, as a compensatory technique, you're going to take notes. And so, shut up.
You're going to write big enough so yourself can read.
Right, yeah. And this is actually a good way because, again, as we're having this discussion, I didn't want to leave something out that would be important, that I would find a value. So I'm going to look at my notes and be like, oh, okay, I'm going to use this as a compensatory technique. And so that would help me jog my memory and being like, oh, I need to talk about this. Sometimes we will, in their phone contacts, we'll use a picture of a person, and then that kind of helps, jog that memory. Okay, I know who this person is.
Because maybe they can't remember the names.
Exactly.
Or maybe they're having trouble reading words, but they can dial the number with the picture of the person
face.
they remember.
Yeah, exactly. And so, and again, that we would call that using prompts. And so, again, medication reminders. And a lot of people, I would say a lot of people, but sometimes what I'll encounter is like, oh, I forget to take my medications at such and such time. Or, we use the pill organizer, and we all have cell phone. Well, not all of us, but a lot of us have cell phones, and we'll set timers to, and with voice commands of like, hey, take your medication. Just having an alarm, that's one thing, but it doesn't cue you. Some people find that's annoying. It's like, okay, well, I don't know what this ringing's for, so there it goes. But if you have something telling you, hey, look, let's take this medication at this time, then, oh, okay, cool. The other thing too is come into your therapy sessions, because we can work on different techniques, especially those with like I know this isn't memory, but like aphasia, for example, that would be something that we can also work on, especially with like speech therapy as well. But then again, with memory, exercise is going to be one of those important things that we want to do, because we want to, prime the cortex for learning and then work on those exercises.
And physical exercise has been proven to improve memory.
Yes.
Whether or not you've had a stroke.
Yeah, and we've seen it. We've seen improvements. I mean, it's there. I mean, it's just, and then it's amazing when it happens because it feels good. It makes us all feel good. So, yeah.
That's great.
Feel good.
And for driving, if someone has not been driving since they've had a stroke, but their doctor technically told them they could, what are some things that they need to have in consideration?
It really depends on when was the last time they did drive, because you've got to think about when you stop driving for an X amount of time, then you got that anxiousness about being out there, because when you're at home or even in a hospital, you're in a very static and controlled environment, right?
Yeah.
So you've got to think about when you get out on the road, that's very dynamic, very chaotic. And so usually I'll tell people, let's kind of scale back, even though you don't feel like, you may have any issues. Once you get into heavy traffic where you got to do visual perceptual skills, executive function, they got to be firing like this, that's when I'm like, okay, let's kind of pump the brakes. Let's, do some therapy first, or let's kind of, talk about the driving aspect, hold off and, talk to your healthcare provider, because that's going to be the most important thing. Doctors, they only see you in one setting. They don't see you outside of those, those four walls. And so I have a tough time saying, oh, you can drive. Well, actually, I have to see them, how they interact and how, how their skills are. before I even say, yeah, I think you can drive.
And I think you hit a good point with anxiety. A lot of people who have a stroke experience anxiety and depression. And I think we all, as the world, experienced a lot of new anxiety over the isolation we experienced in the pandemic. Otherwise, outgoing people who were used to seeing lots of people every day, once they went out in public, even if they weren't afraid of germs, they're like, how do I have normal conversation?
Yeah.
And
Right.
so it was helpful to incrementally branch out and step back into those things gradually. So if someone has been medically cleared to drive, but they have a lot of anxiety about it, do you think maybe small steps like drive around the neighborhood to start with, and then drive around a smaller place that's not a main highway could be a good way to ease into it? Or what do you think?
From my standpoint, I would be very careful with that because anything can happen. You can sit there and tell me that something is very familiar. You've driven a route 10,000 times, but the moment you add one new piece to it, you're no longer it's novel. Because, like, for example, if I'm driving down the street and I've done this 10,000 times, well, now if I add one car parked on the side, you don't know whether or not a kid's on the other side throwing a ball. And so here you're saying, oh, drive around the neighborhood. Congratulations. Well, if you get in a wreck, well, guess what? Is that due to the stroke? Is that due to another reason? And so from a law standpoint, as a therapist, if I say, hey, look, you can drive, and then I feel like you kind of borderline negligence, So I can't tell somebody, go drive around the block, it's fine. No, I'd want to see them, see how their skills are before I even mention driving, to be quite honest.
So then what should someone who has had a stroke do to make sure they're safe to drive?
Besides seeing like a driving, professional.
What
like
if there's not one in their area?
And so what you can do is go, they do have like other schools that even like small towns have like a driving instructor that might be able to be like, hey, what do you think?
You mean like the DMV driving class?
That would be one step that you could use, but again, with the medical review board, that's a whole nother issue.
Oh.
But that might be one avenue that they could take, go to a rehab facility and be like, okay, do you mind looking at my, executive function, visual perceptual skills, and we're big advocates for, even if you have like a small stroke or a large one, anywhere in between, go do therapy, because there's some gains that you can still make, even if you don't feel like, oh, my balance is okay. Well, walking alone doesn't challenge your balance. You got to get outside your base of support, and that's how you really work on it. So with driving, I would definitely go get an assessment by like a therapist, kind of see where your skills are, and then take the appropriate steps from there.
What if it's been a while since their stroke and they didn't get an order for therapy when they left the hospital, and it's been a year? Can they get an order to go to outpatient therapy?
Yeah,
of course.
All you have to do,
Who would they get that from?
You can pretty much talk to any provider, but you can also
Meaning a doctor or a nurse practitioner?
Doctor or nurse practitioner. So, talking to whoever, neurologist, primary care physician, just say, hey, I'm interested in doing therapy. If you know a place, they can send it there. If not, I guarantee you they could probably give you a handwritten order, and you can find a place close to you, or one that you think would specialize in different treatment techniques.
Excellent.
Yeah.
And you guys talk a lot about neuroplasticity. You've lectured on it to patients as well as
Once or
other
twice.
clinicians, which is why we're doing this today, right? So what are some of the principles of neuroplasticity that you want people who have survived a stroke or their caregivers to be aware of?
I think two of the big ones that you could kind of lump together is use it or lose it, and use it to improve it, right? So if you kind of have the capability of doing something, say with your left arm, which was impacted after a stroke, right? You want to use that, because one problem is a lot of people have learned non-use to the point where if they were left-handed and that was a side that was affected, they'll then just do everything right-handed. So then that left side just gets weaker. It it doesn't have the same coordination that it did even after the stroke. So kind of whatever function it had just worsened. But the way that you combat it is you use it. So that way you can actually kind of learn different ways of using it and kind of improve your capabilities. So one day you may only be able to reach for the cup, but not necessarily grasp it, but continuing to work on it, whether it be at home or in therapy. I guarantee you, if you were with Keegan, that would be part of your homework. So
Of course.
1 week you may not be able to perform that grasp, but the more you do it, the practice, you'll then be able to grasp it. And Keegan can probably talk to this too. There's definitely the use it to improve it, but I'm also a big proponent for, more normal movement patterns. So I'm not saying that you don't do something if it doesn't look normal, but if you notice that, yes, your left side is not working as well as your right side, try and take note of kind of what it looks like when your right hand reaches for something and mimic that with the left. But by all means, use that involved side as much as you can.
Mm-hmm. Kind of going off that, really honestly, if you really think about that, it's like learn non-use. And so if you really want to sum that up, that is one of the biggest things that we see.
It's learned non-use.
Yeah, because again, what Colin was saying is, if I can't reach this bottle of water with my dominant hand, I'm going to forget about it, and then I'm going to pick it up with my left, and that's how I'm going to function. And so the more that you don't, again, not to just recap, but the more that we don't use it, we're going to lose it. So, and the other thing too, again, we have to understand that every principle of neuroplasticity, we like them. I mean, they're all important. But if we had to pick, you're going to combine everything together, to be quite honest. So repetition and intensity. I mean, trying to engage in something for 45 minutes in a therapy session, if you think that's enough, whoo, doggy, it is not. I mean...
Yeah.
I mean, it really isn't. You got to do this thing like 2,000, reps in a day. I mean, it's a lot, and it is work. And so the more that you actively engage in it, if it's that's the other thing too, if it's meaningful, you're going to have greater outcomes. And then, just being like, well, guess what? I'm just going to pick up my bottled water because my therapist told me to. Well, guess what? You're not going to make gains, to be honest, because, I mean...
It's not motivating.
Right.
So really their time spent with a physical or occupational or speech therapist is like a lesson to teach them what to do at home.
Yes.
It's not like you have to come to therapy appointments every day for the rest of your life. It's you come here to learn what you can do every day in your daily life at home.
Yeah, because, if you think about it, if you're spending 45 minutes to an hour with one therapy, you may see PT, OT, speech, but the time that you're there, even if it's 1 time, 2 times a week, the amount of hours that you are actually in that therapy clinic is very negligible compared to the amount of time in a given week. So, I said Keegan would give you homework. If your therapist does not give you homework, ask. Because like you said, it really truly is a lesson. Now, in therapy, ideally, you wouldn't be doing the same thing that you do at home. We would make it more challenging, do various different tasks.
Because if you can stretch that far in your therapy session, you can do a more modest amount at home.
Well, it's also there's not a whole lot of skill in doing what you do at home in the clinic. So, it may involve similar tasks.
Because you guys even have a whole kitchen set up and stuff where people can practice doing daily tasks, right?
And that kind of goes with transference. You want to sit there and do something in multiple areas, because if you, like in the therapy gym, if I work on one set of skills and that's all I practice it and I don't do anything at home, you're not going to make it. So you want to have that skill, and going with Colin, you definitely want to do that at home because that's your home environment.
Yeah.
And then kind of like another therapist and I were talking, and I was watching another continuing education course when learning about all this fun stuff. Going to the bathroom, right? We do toilet transfers in the clinic. We work on it. If that's the only toilet they use in life, good luck. Because if you're 100 miles away, well, sorry, butts your lip, buddy. But that's the reason why we practice it in other locations. We get that transference of different situations at home, public. You know, that's the important part.
Yeah. You learn it much better when it's in different environments. So it can be it's the same thing. It's a toilet transfer, but the setup may be different to the point where, you know, the toilet seat may not be the same height. You may have a grab bar, you may not.
Right.
So it just having the capability of doing it in various different environments actually helps promote that learning.
Yeah, definitely. You get those common denominators set. Let's see. And then, did that cover all the principles of neuroplasticity?
No.
Did we bundle them all together?
We talked about age because age matters. Obviously, the younger you are, your brain is constantly undergoing changes, and those changes decrease as you age. But no, we did not hit on all of them.
There's so much more to learn.
Oh, yeah, exactly.
So if you are curious about neuroplasticity and how you can learn more about these similar things, we've prepared a document for you guys to see as a PDF. It'll be in the show notes of this podcast. If you're watching on YouTube, click in the comments, down by the comments, and then tell them what you think of of the document that they prepared for you. And good or bad.
Yes.
Mostly bad.
But I really appreciate your expertise in this area, because what we wish was common knowledge is not common.
It's not.
But it is addressing a common experience. Like, so many people that have had a stroke have these similar issues. So I hope you realize, if you're one of those people, that you're not alone, and there are people you can talk to about it, either in support groups or by getting a referral from your primary care provider to find some expert help for yourself. So listen in for our next episode of the Stronger After Stroke podcast, and I'll see you there.
Thank you for having us.
Thank you.